part of SCRMP is a step towards enriching your professional journey and contributing to a global vision for better healthcare. Now, it's my privilege to introduce today's esteemed speaker, Dr. Payal ma'am. She is a passionate and dedicated medical doctor, having a rich experience of more than a decade, with 8 years in the pharmaceutical industry and around 4 years in clinical practice. She is currently working as senior drug safety physician with expertise in signal detection, aggregate reports, and ICSR review. She is currently serving as a subject matter expert and safety risk lead counterpart in her organization. She also serves as a board member and national joint secretary of Society of Clinical Research and Medical Professionals and editorial board member of JPADR, which is Journal of Pharmacovigilance and Drug Research. Without any further delay, please join me in welcoming Dr. Payal ma'am. Over to you, ma'am.
Thank you so much, Prisha, for this wonderful introduction. And thank you everybody who's on the call for joining this session on this Saturday evening. I know it's a weekend. I'm sure everybody wants to, spend time with their families, and yet you all have taken time off and, attending this session. This itself means a lot. Today's session is very interesting. The topic is, we are going to be talking about rare diseases and orphan drug safety. As you all know, a few months ago, we celebrated the Rare Diseases Month. There was a lot of talk, there was a lot of discussion on this. And in the same way, we are also going today to get to know more about it so that the future generations of professionals like you who are going to enter the work field very soon, or you might be already in the work field. So you all have an idea of what kind of arena it is, what is the current scenario, and what are the future prospects of rare diseases. So without wasting any more time, I'd like to share my screen and I'll start the presentation. US and other countries' situation is very different. So it causes a significant economic burden. So this burden will include healthcare systems also. So 7.9% of total drug expenditure in the US, despite treating only very small population, it's very high. The proportion is very high. Because of this high prices, patients don't take the medication because they can't afford it, right? So there is medication non-adherence. So they end up skipping their doses. So all these factors, they combine, it's a very complex environment that gets created. We need the innovative treatments, but it is so high that there is no balance. As a result, there is no affordability. We don't know the adverse events. We don't know the long-term efficacy. So all this becomes so challenging for people. This industry itself becomes so challenging. That there is a need to somewhere bring in some change to streamline the whole process of this entire scenario. So coming to why is this monitoring so critical? Why are we even talking so high? So as we said, that labeling changes are needed. So like orphan drugs require safety-related changes within 5 years. 40% of the complications are not even recognized, and cost reduction through early intervention and proper monitoring is needed. If done properly, the cost can reduce. It can lead to a 30% cost reduction. Coming to the topic of pharmacovigilance in rare diseases. So what are the things that help in getting those adverse events to the sponsors? So there is something called as a disease registry. Okay, so there is what is disease registry? It's a database. So it systematically collects and tracks the information about individuals diagnosed with specific disease or condition. So they are developed to improve individual population care, and they can be valuable for research purposes also. So patient outcomes, study treatment effectiveness, trends in disease prevalence and management is something which they are specifically designed for, these disease registries. And data is collected to define the population, like patients with specific type of cancer or certain specific geographical area. So whatever patient population you want to select, you can do that and then collect very specific data on that. So there could be hospital-based registries or population-based registries, and they can include any type of condition that you want. Now, coming to rare disease, they play a very crucial role in their rare diseases and patient care. So there are over 800 rare diseases registries worldwide, which covers approximately 20% of known rare diseases. And These registries contain data on more than 1.5 million patients. And it depends on clinical disease prevalence, but the data is quite robust as compared to the clinical trial that is there. And registries have contributed to 35% of post-marketing assessment for orphan drugs. And they have been instrumental in 22% of rare diseases drug approvals. So whatever data you get, they have led from these registries. You can use it for identification of new symptoms, enhancing the understanding of the natural history, and patient-reported outcomes are also included in rare registries. So all these factors provide a very valuable insight into the rare disease burden and treatment efficacy. 75% of patients involved in these registries report improved care coordination. But again, challenges are there even with the patient registries, and these include only 30% registries have standardized data elements, complicating cross-registry comparisons. But still, there is still, hope, and there is also, like, they have reported to have a 27% increase in clinical trial enrollment for rare diseases. Economically, if you see, 50 to 60% less expensive than clinical trials. The data is valuable and it is less expensive. And the future looks promising because there is an effort right now going on to create a global rare disease registry platform. So what it aims to connect 70% of existing registries by year 2027. So that the rare disease research and data collection that is revolutionized. So we have covered this approaches, patient registries, real world data sources. Okay, now let's talk about real world data sources, what we also called as the real world evidence. So let's talk about that a little bit. So real world evidence is a clinical evidence about the use, potential benefits, and risk of any medical product. And it is derived from analysis of real world data. The data is related to patients' health status or healthcare delivery. It is collected routinely from different sources or outside of traditional clinical trials. So in the field of rare diseases, it is becoming really vital. 95% of rare diseases lack FDA-approved treatments. So in that case, real-world evidence, RWE, is crucial for understanding the disease progression. It is used 40% of orphan drug approvals since year 2015. It has also led to identification of new symptoms in 68% rare diseases, and it enhanced the understanding of natural history. And also, there was a 30% reduction in recruitment times for rare disease orphan drugs. Again, in this, as we saw in patient registry, here also the patient-reported outcomes was a key component, and it was also a part of this evidence. And again, even these studies are 50 to 60% less expensive as compared to the clinical trial. Again, challenges are also here pertaining to standardized data elements. As a result, cross-study comparisons again becomes a problem. But still, this is a very promising tool as comparative to the patient registries. And this is something which is really having a potential to improve outcomes in future for rare disease patients. Now, there's something called as some international collaborations are also currently into picture. So there is something called as the International Rare Disease Research Consortium. It aims to develop 1,000 new therapies of rare diseases by 2027. There is something called as a European Reference Network. So it connects 900 healthcare units across the countries, and it has 24 rare disease groups, and it is currently benefiting 13 million rare disease patients. There is something called as global data sharing initiatives like Matchmaker Exchange. So it has revolutionized the gene discoveries, and it connects the data sets of almost 13 countries. There's also called as Global Alliance for Genomics and Health, 𝗥𝘅. It has developed standards adopted for 90% of large-scale genomic data initiatives and initiates interoperability. And they are coming together. All these agencies are coming together. They are coming together for collaborative efforts, and it reduces the time for diagnosis by average of 1.5 years. This is something we should be aware of. So let's talk about a real-life case study, and let's see how all these interventions that I was speaking about, it led to an upscaling of rare diseases outcome in a certain disease. So let's talk about Pompe's disease. So there is something called as enzyme replacement therapy. So there is an enzyme called as glucidase alpha that is needed for Pompe's disease. replacement. So you need to replace it for treating it. So patients have to be given this ERT. So it is a notable case that provides how orphan drug monitoring is critical in these cases. So in the initial trials, so you see in the timelines, in 2006 it was approved by FDA. So what had happened is in the initial clinical trials, there were 39 patients and 51 patients of them experienced infusion-associated reactions. So they did some post-marketing surveillance and it revealed more serious adverse events with anaphylaxis that was occurring in 1% patients and 14% developed high sustained antibody titers. So what happens if you have this? There is a reduced treatment efficacy. So in 2010, a pivotal study was conducted. It involved 90 patients. And it was reported that 91% patients experienced at least one adverse event, with 7% discontinuing the treatment due to safety concerns. So when these findings were coming up, it led to enhanced monitoring protocol, which we, as already discussed, is very critical in these patients. As a result, a 𝗪𝗠𝗃's registry was established. So in year 2004, 𝗪𝗠𝗃's registry got established, and it now includes over 1,000 patients from 26 countries, and it has become critical for the follow-up of these patients. So continuous cardiac monitoring during infusion was instituted in these patients because the risk of arrhythmias was identified. So FDA has now mandated a risk evaluation and mitigation strategy. So it is REMS. So FDA now requires that all the healthcare providers should report all serious adverse events. So now you can see an example, from this example, we have learned that a comprehensive approach has led to 30% reduction in severe infusion reactions over the 5 years. And because of establishment of registry, there was a very drastic improvement in survival rate.
Yeah, thank you, ma'am, for the insightful session. We will now open the floor for questions. Feel free to ask anything related to today's discussion or the broader aspects of orphan drug safety.
I think I can see something on the chat. So, what is the shortest pipeline for development? So, what exactly do you want to understand by the shortest pipeline for drug development? This is a very broad question, so I would like to understand it. Okay, this is actually a very broad question. So, shortest pipeline, I do not have the. If you see the rare diseases drugs and the timeline to take for the development of the whole molecule, anywhere between 7 to 10 years is the average that goes. But I really cannot comment on this right now. But then the shortest pipeline, I really don't have a figure for you, so I'm not sure I know this one. And repurposing I don't think so that it is possible. Whatever I've read, I have not come across the repurposing, whether it is